This student is portraying a 65-year-old patient with the neurological diagnosis of a right MCA CVA. She is using her right upper extremity to help support her body weight in sitting, and she is displaying an asymmetrical sitting posture as she is leaning toward the right unaffected side. Her overall sitting posture is slumped. Notice that the left upper extremity appears to be spastic. The left side is weak, and the right side, both upper and lower extremities, are of normal strength and tone. Currently, the patient is able to perform a sit-to-stand transfer, but requires extra time and effort as compared to her cohorts. During the flexion momentum phase in the frontal plane, the patient is asymmetrical as she shifts her weight towards the stronger right side. In the sagittal plane, the patient has decreased forward movement of the center of mass over the base of support. The patient has decreased trunk flexion and decreased anterior pelvic tilt. During the momentum transfer phase, the patient has difficulty gaining momentum to perform this phase due to the lack of forward translation of the center of mass over the base of support in the flexion momentum phase. She rocks forward several times to gain the appropriate momentum to complete this phase. Also, she uses the right upper extremity to assist with gaining momentum. The body continues to be asymmetrical with the center of mass traveling to the right unaffected side. In the extension phase, the patient has difficulty partially due to the ineffective previous phases. The patient is therefore moving slower and needing to rely on the strength of the right upper extremity pushing from the table and the right lower extremity bearing most of the weight. The extension phase is asymmetrical as the patient leans to the right. The left lower extremity is not as involved due to the body weight shifted to the right side. The hips and knees go from flexion to extension but never reach full potential range. The trunk also never achieves full extension and rather stays in a flexed position. The patient moves slower than a normal adult of the same age. Lastly, in the stabilization phase, the patient has difficulty stabilizing without an assistive device. She is relying on her knees on the back of the mat table to assist in her balance. The hips never achieve full extension and the knees are in slight flexion. Weight bearing is asymmetrical with the center of mass more towards the right of midline. The upper body is in a flexed position and it takes longer for the body to stabilize once standing, and the patient seems unsteady standing independently. The goal of this treatment session is to improve symmetry of the transfer, equalize force production, improve efficiency and symmetrical weight bearing, decrease insecurities about stability of the lower extremities, and improve the use of the involved side. The following interventions were chosen for performing a sit-to-stand transfer with a more normal symmetry. These were used to help facilitate muscle activation of the involved left side and improve force production to complete the transfer, as reduced force production has been identified as a major factor in the difficulty of a sit-to-stand transfer. The patient is first positioned so the feet are flat on the floor, shoulder-width apart, and the feet are positioned behind the knees. The patient is instructed to move forward on the mat table, and cues are given for proper spinal posture. Proper posturing will be important in both treatment techniques. The upper extremities are placed on the large Swiss ball, which is located in front of them, and the patient rolls the ball forward and back symmetrically. This helps the patient learn and improve moving the center of mass forward over the base of support in a more symmetrical pattern, which will help improve all aspects of the sit-to-stand transfer, especially during the flexion momentum and momentum phases of the transfer. The therapist initially assists with manually directing the motion forward by sitting on the involved left side to ensure correct technique. During this intervention, the therapist is evaluating if the patient is able to go from manual assist to move forward in the proper direction to be able to perform this exercise without assistance. As a progression, when appropriate, the patient would be instructed and manually assisted in progressing to moving the ball in different angles to the left, center, and to the right, as well as moving farther into the range, and then beginning to try to lift the buttocks from the mat table. In the second treatment scenario, to improve symmetry and use of the left lower extremity, the patient is first instructed again in proper positioning and posture of the body. The patient is instructed to clasp the hands together to engage the left upper extremity as well as to inhibit the right upper extremity from pushing and causing an abnormal symmetry of the body during the transfer. A target is pointed out that is centrally located for the patient to focus on to help keep the transfer symmetrical. The therapist stands on the patient's involved left side to help guide the center of mass anteriorly over the base of support and symmetrically by using manual contact on the lower posterior trunk and upper extremities, guiding the patient forward and up. The patient is given verbal cues to aim for the target with her hands. As the transfer progresses, the therapist uses her knee to block the patient's left knee to prevent buckling and is tapping the left hip and trunk extensors to facilitate improvement of the extension phase of the transfer. At this stage of rehab, force production is targeted as a momentum strategy would require more stability than the patient is able to control at this point. The therapist again practices the transfer and is looking for the patient to require less assistance with verbal and tactile cues and manual assistance as the patient demonstrates improved symmetry, thus improved force production of the left lower extremity, leading to overall efficiency, safety, and independence of the transfer.